Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai. And today, who is with us? Professor Bhandari Mohit. No doubt, he is live legendary bariatric surgeon. And I can ask, so he changed total culture of bariatric surgery. And you all know how he is doing and every day, how many cases. In my opinion, at the globe, one of the most busiest center is Mohit Bhandari Center. Sir, so much thanks, really. It's great honor for me, for my viewers, for our global laparoscopy and robotics, sir. Over to you, sir.
Thank you, Dr. Imran, for inviting me. You are doing a great job as usual, not keeping the knowledge to yourself, but helping it disseminate to everybody. Thank you very much for having me on your show.
Sir, so much thanks again. Thanks, because I remember your participation in our interview series of MGB OAGB that was for 6 months. Then safe sleep gastrectomy, and now Roux-en-Y gastric bypass. Because as you know, these three are one of the most common bariatric surgery, especially initial bariatric surgeries. So regarding this, we will continue. We have started this series with Professor Himpan, who is also another legend, and we continued this now. And hopefully next month we will finish, and in June we will have some obsession. Sir, personally, I know, but we love you, and my viewers also know about you, your brief introduction, your journey of bariatric surgery, and especially Roux-en-Y gastric bypass.
So, Dr. Imran, as I was trained by Professor Phoebe, we were the first ones in the country to start gastric bypass. And usually surgeons would start with sleeve gastrectomy, but I was one surgeon who started my practice with a gastric bypass. We started doing them in 2008 and 9. Then we opened 2 new centers. So by 2010, we would have already done 1,000 gastric bypass. So today we do, operate at 5 different centers in country, and also East Africa, and we do close to 1,000 gastric bypasses a year. I'm not talking about mini gastric bypasses, but I'm talking about the conventional Roux-en-Y gastric bypass. That's one of the most common procedure, one of the most common done in the entire world, and also at our center. If we see our case mix, I must have done, as our team taken together, close to 6,000 Roux-en-Y gastric bypasses, both banded and non-banded conventional gastric bypasses, and we published a lot on them, a lot of data from our center.
Sir, excellent. Sir, excellent. So one thing that always I talk with other colleagues, different times I have talked about you. One thing that is the dominant in your practice, you are doing all types of surgeries, not only highlighted one. This is very important. So definite you are following proper patient selection, indication, everything. So we are also interested to know about relative and absolute contraindication of Roux-en-Y according to your opinion.
Yeah, so as you correctly said, we do all 3 procedures. We do sleeves, we do mini bypasses, and one anastomosis, and we do a conventional bypass. Now, for the sake of simplicity for your viewers, we have devised a very simple algorithm. Very simple. So everybody can understand. It's very evidence-based and it is very logical. So we would do Roux-en-Y gastric bypass in patients with hiatus hernia, patients with established gastroesophageal reflux disease, patients who have mild to moderate diabetes, and also have a bad liver, which makes a contraindication for one anastomosis. So these are, good indications, mild to moderate diabetes, established gastroesophageal reflux, and a large or maybe even a small hiatus hernia in my practice. Absolute contraindications. I don't think there is any absolute contraindication to a gastric bypass. If you can do a sleeve, you can obviously do a gastric bypass, but specifically in young unmarried individuals, very, very high risk patients, where you need to have a very short operative time, we avoid a gastric bypass. I think if you have to do a bypass procedure in a patient where you need to do a short procedure, one anastomosis would be our preferred option. Apart from that, I think there are no specific contraindication to a conventional bypass. It's a very standard, very old procedure, very safe procedure, I would say. If the skill set of a surgeon is good and he's well trained to do it, it's a very safe procedure.
Sir, so many thanks. So according to your opinion, so we can do, but if patient is suffering with Crohn disease, or so this diagnosed child C cirrhosis, in such a case, how you deal the patient? Patient is
so see, let's discuss these two cases separately. Crohn's disease. If the patient has Crohn's disease, we usually do a sleeve, all of us, we do not do, because I believe that Crohn's disease patients might have ileal strictures, might have even, sometimes you have even colonic strictures and all. So to touch the small bowel in such cases would be, but this is very advanced Crohn's disease, where we know that the ileum is probably involved and the patient is not well controlled by the drugs. As far as the liver cirrhosis is considered, I would specifically say that liver cirrhosis is not a contraindication. Child C, obviously, child C, sleep should be preferred, but until child's B, I would still do a gastric bypass if the patient has a hiatus hernia, GERD, or mild to moderate diabetes, because I believe that gastric bypass is not a malabsorptive or a hyperabsorptive procedure. It's a restrictive procedure. Our limb lengths are not very aggressive in India, and also other parts of Asia, and now even in the world, the limb lengths in row-wide gastric bypass are not very aggressive. It's a restrictive procedure, and that's why we believe that because of its restrictive nature, it still can be offered until child's B. Child C, yes, depends, but we can offer a sleeve. In fact, in most of these cases, usually we are now going for non-surgical methods. I'm not operating patients with child C at this point of time. We have several other modalities which are non-surgical, endoscopic, to offer to these patients if they do not suffer from varices.
Sir, so much thanks. Sir, regarding smokers, heavy smokers, so this is also another issue. And maybe after surgery, so this is marginal ulcer is really, it is just like a disaster in my opinion, because you face such a situation. How you deal these patients?
We have done gastric bypass on smokers. Our data which we publish does not reflect that they have a higher incidence of marginal ulcers. In fact, the etiology says that there is more ischemia, but even on patients with chronic smokers, we have done row-wide gastric bypasses, and the rate of marginal ulcer is same when compared to the non-smokers in our series. So chronic smoking per se, as per our own data, is not a strict contraindication to conventional gastric bypass.
Sir, a patient suffering with osteoarthritis and used long time NSAIDs. So the patient must use after surgery also NSAIDs. So in such a situation, have you any experience? You have experience?
We have done gastric bypasses in such patients. I'm personally avoiding one anastomosis. To be very honest with you, one anastomosis has more marginal ulcers in my own case, because the marginal ulcers are produced by the acid load. You have to understand that these are more on the side of the small bowel. So we make a very small pouch, and therefore, the rate of marginal ulcers, and plus it's the technique by which you do the gastrojejunostomy. If the technique causes a lot of ischemia, even the smoking, this ischemia of smoking is much less than the ischemia of gastrojejunostomy. Most surgeons fail to understand this. So to me, a very small gastric pouch is a good thing. It does not cause us that high marginal ulcers. We avoid a one anastomosis, absolutely. So all questions you asked to me, my contraindications like osteomalacia, NSAIDs use, chronic smokers, these are the cases where I would strictly avoid a one anastomosis, because we are dealing with a very, very, very large pouch, a lot of parietal cell mass. Uh, so there is a double hit hypothesis here. The double hit hypothesis is that uh, when you have smoking, when you have NSAIDs, when you have factors which causes ischemia of the mucosa, but you have a large parietal cell mass. It's a it's a double jeopardy. There's a situation where you have so if we compare our own endoscopic surveillance series, we published this data: gastric bypass versus one anastomosis. The rate of marginal ulcers in one anastomosis was around 10 to 12%. Whereas in a conventional gastric bypass, it was around 1 to 2%. Smokers, non-smokers, equal. So, and it's a large data. It's like 3,000 plus patients exposed to surveillance. So my experience have changed. All I'm speaking is in the light of my data. I would seriously not consider smoking as a very strict contraindication to ROI.
But sir, definitely, you ask to your patient to quit smoking and suggest them, or no, there is not compulsory.
Everybody asks patients to quit smoking and quit alcohol. Everybody, all patients are put to the multidisciplinary team, but the point is that 1 to 5% of not more than 5% would comply to the multidisciplinary team, and therefore. It would be a little surprising for you, but 95% of them would continue to smoke and continue to have alcohol, and that's a lifestyle issue. It's not easy to quit smoking. It's very difficult. We have tried everything, but 5% adherence. So my strict contraindication is one anastomosis, not a gastric bypass.
Sure, sir. So regarding patient, just because we have just divided this question, patient selection. Then we will touch technical points, and at the end, some post-op. So in this patient selection, just imagine a patient after menopause with symptomatic osteoporosis, and how you deal. It is compulsory to treat osteoporosis, and because when we bypass this proximal jejunum, definitely there is chance of hypocalcemia and deficiency.
Yeah, so I have adopted a very different strategy nowadays. See, the problem is that specifically in Indian females, you have a lot of osteoporosis, a lot.
Yeah.
And I was facing this problem because these females also have anemia. So do not forget anemia. It's also a very important thing. And plus, these females used to get a lot of gallbladder stones also post-bariatric. So we were dealing with anemia, we were dealing with gallstones, and we were dealing with osteoporosis. So what we did for these patients was that, and plus we have to understand that these patients also had severe diabetes. You know, in your country, in my country, we have very bad diabetes. So we need a bypass procedure. I'm very clear about that we do not have the same incretin effects by a sleeve, although people may say that's a GLP-1 effect, it's a ileal break. The amount of GLP-1 is very high, secreted very high when you have quick stimulation of the terminal part of the intestine. There is no doubt about that now. There's a lot of publications. So what we did, we changed. So as you asked, what is the strategy? So we changed from a conventional gastric bypass to a transit bipartition. And there's a transit loop bipartition. So what we did, very liberal sleeve, starting above the incisura, and a loop of 150 centimeters anastomose to the greater curvature of the stomach. So the food will go both the ways, and we have great amount of data now, almost 500 plus cases. So this is offered to females who are severely diabetic. They need a metabolic procedure, and sleeve is not a good procedure in them. We cannot do a bypass because, as you correctly said, the first part of the duodenum will be completely gone. Patients have osteoporosis, they have anemia, but still they need a metabolic procedure. So we changed our bypass and we came to a transit bipartition, where you have a very liberal sleeve above the incisura, and you have a loop of 150 centimeters to 180 centimeters anastomose with a large anastomosis, just like a mini bypass to the greater curvature of the stomach at the level below the level of incisura. And so the food dumps, 60 to 70% of the food would dump directly into the intestine and would cause a very good GLP-1 secretion, and around 30 to 40% would still go to the duodenum, and these patients definitely have very less incidence of calcium, iron deficiency. And we're going to publish this data. When we compared them with the conventional bypass, the rate is less. So the strategy to treat diabetic females who are anemic and having osteoporosis is not to do a sleeve, but to give them a little different kind of metabolic procedure, which is a transit bipartition.
So it will be like SASI. So this is not SASI because just you attach jejunum loop.
Yeah, so it would be SAJI basically.
Yeah, definitely.
It would be transient. It could be a bipartition with a transit bipartition with the jejunal anastomosis. So that's a model. It's a very different kind of sleeve plus procedure. It's a very different kind of sleeve. But it adds a lot of value because we are able to have three advantages. Number one is we definitely have very less incidence of iron and calcium deficiency. Number two, we have a good access to the biliary tract. Number three, very good resolution of diabetes. And number four, which is very important, is that these patients, they have a very good incretin effect, a lot of GLP-1, because this is a very different surgery.
Yeah.
It's different than a bypass. It's even different than a mini bypass.
Yes. Sir, regarding age limitation, have you any age limitation for this Rohan Bhai for adolescents?
No, I've done a lot of bypasses on adolescents. I published on it. A lot of bypasses, and let me tell you, the adolescents who are voracious carbohydrate eaters, gastric bypass is a very fantastic procedure for them. I don't consider adolescents as a contraindication. Obviously, we are not operating patients 8 years or 7 years or 6 years. Those are the patients where we strictly offer a sleeve. If there is very severe obesity, we operate on kids. But patients above the age of 14 years, 15 years, once the bone development has happened, I think it's fair to offer them a gastric bypass. It doesn't stop us.
Yeah, sure, definitely, sir. Now we will talk a little about technical points. So definitely, I am talking with someone who has experience of Rohan Bhai gastric bypass more than 1 decade. You have started this in 2008. Every surgeon with the journey of any type of surgery evolute. This is the evolution of technique. So we are interested to know about some changes of this Rohan Bhai gastric bypass during this journey of Rohan Bhai gastric bypass. The size of gastric pouch, size of this gastrojejunostomy, and if you want to highlight these points.
Yes, so very important. So, we started with a very, very large pouch with a little, very small gastrojejunostomy. So that's what we started, large pouch and small gastrojejunostomy. But when Dr. Phoebe came into our center, he changed a lot of things, and then we standardized our gastric bypass. And now what we are doing is a very small pouch, 30 ml. The length of the pouch, which we published in the BMSS meeting, and that's one of the procedures we standardized along with 52 other bariatric procedures. The length of our pouch is around 6 to 8 centimeters, and the width of the pouch is around 2.5 centimeters. The capacity of the pouch is 30 to 50 ml, and the size of the gastro J is 2.5 centimeters. So it's not 1 or 1.5 like we used to make previously, because it causes a lot of stricture. So 2.5 gastrojejunostomy, 5 to 6 centimeters length of the pouch, and we banned all our gastric bypasses. We have a lot of data on that. That's the thing. We closed both Peterson's and both the internal hernia defects. And yeah, this is our technique. It's pretty much standardized over the years, and now I think 2.5 centimeter gastro J with the 60 ml pouch is standard in gastric bypass.
Sir, excellent. Really, in this short, just you have explained completely regarding BP limb. That is definite. I don't think next decade also we cannot standardize this BP limb at the globe due to different ethnicities, different diet protocols. So what is your experience? Yes, I understand the more your part is restriction, but again, just imagine a patient with BMI 60, a patient with BMI 40. So have you any standard for your BP limb, age, BMI, comorbidities?
So again, interesting question. So if I have to operate a patient of BMI 60 and I have to offer him a bypass procedure, I would do a one anastomosis. Why to do a gastric bypass? I don't see my indications for gastric bypass are very standard. Patient with gastroesophageal reflux disease, uh, large hiatus. These are the kind of patients, mild to moderate diabetes. If I have a patient with 60 BMI and at all, I have to offer him a procedure which is very strong. It would be a one anastomosis gastric bypass. So my limb lengths are very standard. 80 centimeters of a BP limb, 100 to 120 of an elementary limb. Now, why I do not increase my BP limb? Because if at all I have to increase my BP limb, I'll do a one anastomosis. I will not do a gastric bypass in such cases. The only one case, I would say, indication to increase a BP limb would be to convert sleeves into a row Y gastric bypass. So when we revise failed sleeves, yes, our BP limb is around 150 centimeters and elementary limb still remains 100 centimeters. But otherwise, primary gastric bypasses, 80 and 100 to 120 is very standard for us in our center. And I believe that if at all you want to increase the length of your BP limb, why not do a one anastomosis and give him a proper hypoabsorptive procedure, which we all know it's much stronger than a gastric bypass in terms of metabolic benefits.
Sir, I have one suggestion. Personally, I have no experience. So because why we prefer one anastomosis gastric bypass due to this hypoabsorptive component that is the stronger than Rohan, no doubt. So what is my question? So what is our concern in Rohan? Why we don't increase this BP limb? Because we will bypass all the jejunum. So what is my suggestion? So we can do standard Rohan, just 50 BP limb, 100 your will be Ru, and in same session you do Sugarman. So you can increase. So what will happen at that time? Your BP limb will be ileum, not jejunum. So the main jejunum will be in touch. So that BP, your 50 will be BP from jejunum. 100 is already Ru that absorb that carbs. So when you will add this BP limb with Sugarman, so you will just cut this Ru limb and increase BP limb, then ileum will be the part of BP limb. Have you any idea if you are going to do so stronger hypoabsorptive procedure?
So what you're talking about is strictly when I revise gastric bypasses which have failed.
Okay.
So I do a Sugarman's type distalization very commonly, and we revise a lot of failed gastric bypasses. So the only time we use your strategy, what you're saying, is when we distalize these failed gastric bypasses. I have done many. We resect the pouch, band the pouch, and then just disconnect the Ru limb at the junction, and then distalize it and anastomose it to around 100 to 150 centimeters from the ileum. But believe me, that's not a very simple procedure to handle. A lot of diarrhea, a lot of multivitamin deficiencies and things like that. So a Sugarman type 1 distalization, any kind of distalization you do for a gastric bypass comes with a lot of these issues. We also converted our failed gastric bypasses into SADI. There also we have these issues. So, anytime in Indian patients, even African patients I've revised, the moment you keep a common channel less than 250 centimeters, I have always had a lot of diarrhea, a lot of issues. Even if the patient was a pure non-vegetarian taking supplements, still not very, body odor changes, the microbiota changes. It's a very strong, procedure if you distalize and keep 150 centimeters or less as a common channel. So we do that, but with a lot of consent, a lot of preparation, a lot of follow-up, and making sure that the patient can afford the cost of the supplements, the cost of reversal, the cost of liver failure and things like that. So the answer to your question is I would only do it when I revise my failed gastric bypasses and I have no other option.
Yeah, sir, personally also, in redo surgeries also, I do, but always, so I save at least 350, 400 common channel in revisional. So that was initial surgery. Okay, sir, if in future, so we can talk about this if someone is insists to go for Roux Y. So if we save at least for, because sometimes, so if you measure whole bowel length, that is 800 centimeter, you have lot of bowel, there is no issue, and you must save 300, 350, 400 common channel. If you increase BP limb with this technique initially, maybe it will be more hypoabsorptive and or effective.
Dr. Imran, I'll tell you something. If you are to count the bowel from the ileum,
Yeah,
and do what you want to do, to me, I would not recommend this to surgeons. I would not tell anybody to count the bowel from the ileum because they can damage the bowel.
yeah,
It's very easy. It's very easy to count the bowel from the duodenojejunal flexure. And if at all I want to do a very malabsorptive procedure, I would still do a mini gastric bypass. See, I would use my tools in a smart way, in a way where I would cause least amount of damage to my patients. Believe me, in a patient with a BMI 60, to count the bowel from the ileum and to anastomose it, 10 out of 100 surgeons would damage the small bowel.
sure.
So in such cases, my take is that why do such a difficult procedure? Do something which is very simple. Do a one anastomosis. You have a very low-lying anastomosis. You can beautifully count the bowel from the DJ flexure and never take more than 200 centimeters. Because what data suggests, and we have published a lot on this, at any time when the length of your BP limb plus elementary limb is less than 200 centimeters, don't worry about the common channel.
Sure, sir. Sir, absolutely agree. Absolutely agree, sir.
So my contention is that if at all I have to go for an aggressive procedure, I have a mini gastric bypass, which with a lot of data to suggest that it works very well on super. We have done mini gastric bypass on patient weighing 400 kilos. Very successfully, we could do that. So I would avoid doing a gastric bypass in such cases.
Thank you, sir. Really, this because this I like to hear from your side, and this is message for our youngsters. If they are just now going to start bariatric surgery, please must know not only one type, 4 or 5 types. You must know. Then you must select the case and go the best for the patient.
I think a bariatric surgeon should learn all three.
Yeah.
Sleeve, a bypass, and a one anastomosis, all three. You cannot practice bariatric surgery without learning at least these 3 procedures. And in Indian subset where we have a lot of females having severe diabetes with anemia and calcium deficiency, as you correctly mentioned, we even may see a role of transit bipartition coming in a very big way. So you will see a lot of Indian data coming from my center, from several others, where they want to offer a sleeve plus procedure, which gives less iron deficiency and less calcium deficiency, maintains the duodenal continuity. So you will see a 4th procedure from India, which is a transit bipartition coming, as a metabolic, as a diabetic surgery. I have done a transit bipartition in a BMI. The smallest patient I have operated was a BMI of 26 with a transit bipartition as a metabolic procedure, and patient is doing very well. So you will see a lot of this data coming up. But to answer your question, yes, young surgeons, anybody coming into the field cannot be just dependent on sleeve. He has to learn, or he or she has to learn a conventional bypass, and also now a mini gastric bypass, because it's being practiced everywhere across the world, even in US. So now there's no looking back.
Yeah, sir, definite, sir. Also, personally, I have good experience in transit bipartition in low BMI diabetic patient, and definitely I will share my data, and really excellent results, no doubt. Sir, regarding a patient with hiatal hernia, so large size hiatal hernia, and also indication is the Roux Y gastric bypass. Are you go for, and how you deal, and are you repair this hiatal hernia?
So it's very interesting. I repair the hiatus hernia and do a bypass. But at the same time, I worked with Dr. Fobi for 4 years. He still is on my board, but he's not here. But he was with me personally here for 4 years, and he operated at my center. And whenever a bypass used to come, he never used to repair the hiatus. He used to leave the hiatus. He used to say that a gastric bypass in itself is a very beautiful operation. It pulls the pouch down with the weight of the small bowel, and you don't need to repair a hiatus. I for one, believe that yes, small hiatus, you can leave small hiatus to 2.5 centimeters, but if it's greater than 2.5 centimeters and you have a lot of pouch redundant inside the chest, pull it down, reduce the pouch, very tactfully and very cautiously. With a 38 French bougie, repair the hiatus. It should be loose, should not be tight. Always repair over a bougie, and then do a gastric bypass. So both of us had different approaches. I would recommend that any hiatus which is larger than 2.5 centimeters needs to be repaired.
Thank you, sir. Sir, you have mentioned, so regarding closing of defects, so we are also interested to know about your technique. This is interpreted or purse suture, how you close your defects.
Oh, I always close it with a continuous sutures, and it's always a non-absorbable suture, and it's continuous. Both Peterson's and internal hernia, both continuous sutures. And when we close the internal hernia defect, the jejunal defects, we have to take a Brolin anti-obstruction stitch so that the continuity of the alimentary limb and the common channel are well maintained. That's it. Yeah.
Sir, regarding this gastrojejunostomy, because we had this question, you mentioned, so the size of this gastrojejunostomy is 2.5. Are you use a stapler, linear stapler, and that is side to side, posterior to stapler line?
Yes. A side to side, posterior to staple line, 2.5 centimeters. Absolutely.
Sir, have you any experience of this Rowan gastric bypass that is a retrocolic, like Higa technique?
Yeah, so we used to do retrocolic when we started. It was very simple. I have a trick to do a retrocolic, and that's the shortest route. Very easy. You just need to open the stomach opposite the incisura, the greater curvature a little bit, and cut the omentum below that, and the bowel comes dangling, and then it's very easy. We stopped because it was very difficult to revise these gastric bypasses.
Yeah.
So we stopped. Then we started dividing the omentum, and we started doing anticolic. Now, where would I need the retrocolic technique is a very interesting question you asked. So I would use it when I'm doing a bypass on a patient with a very large hiatus hernia and a patient who has a very difficult mesentery, right?
Yeah.
Because there we cannot do a one anastomosis. Ideally, I would love to do a one anastomosis in cases where we have a very difficult bowel mesentery. But suppose we have a patient with a very large hiatus, a BMI 70, just as an example.
Yeah.
Very large hiatus, BMI 65 to 70, and the bowel loop does not go up easily. In such cases, I still do a retrocolic. It's easy. It's the shortest route of the bowel towards the gastric pouch. The second case where I still do a retrocolic revise, cases where I revise patients with chronic sleeve leak fistulas. So we get these patients to our center from all parts of the world where the patient has a fistula for 6 months, chronic fistulas. And then we need to do a esophagojejunostomy. Now there, sometimes in patients who have such a bad mesentery, persistent leak, so much of edema, it's difficult to get it anticolic. There again, I would recommend that surgeons should learn a retrocolic method because it's the shortest route to the esophagus, and you have to go way up into the thorax to anastomose the bowel. So yeah, these are some of the indications.
Yeah, sure. So, but also someone who is also dealing with the redo surgeries in a tertiary hospital must know about this technique for shortest way, but not this is the preference as you have mentioned.
No,
initial surgery.
No, it should not be the preference. It should not be the preference because it's very tough to revise. Also, one thing which it's very difficult to close the Peterson space. When you take a retrocolic, some surgeons would create a space, then close it.
Yeah.
So it's tough. Yes, Dr. Higa has a lot of experience. Himpins did a couple of them previously. Bruno does still. Our center we used to do, we have that. But the point is that for youngsters, even to our fellows, we teach them anticolic now. But occasionally, when the need arises, I do a retropolic, and sometimes I even do a retropolic in easy patients just to teach them, because they should know how to do it. Sometimes they might have a difficulty where bowel loop is not going up very easily. Specifically for those surgeons who do a jejunal first, right?
I agree.
There you have a roux limb and it doesn't go up. Then what do? For the ones who do the Brazilian technique, the Almino Ramos technique, where you take a loop of the bowel up to the pouch, you can calibrate your bowel. The area of the bowel which goes easily goes for the anastomosis. But suppose you did a jejunal and you have a situation where you're not able to take the loop up, then to do an anastomosis under a lot of tension and get a leak, fellows should learn the retropolic technique. And I it's very interesting. Every month, when Dr. Phoebe was here, we used to do a retropolic one just to teach our fellows. They should know about it, how to do it. Yeah. And it's better to do it on a simple patient, because then they understand the anatomy well. They're able to graduate to a very difficult patient. It's tough to do a retropolic directly on a difficult super obese. Then, first teach them on a simple BMI, and then they, graduate or progress to a difficult one.
Sir, we are interested to know about your opinion about staged surgery. If such a case, they're really difficult to do now due to thick mesentery and thick. Okay, we will do stage surgery. You can do sleeve gastrectomy for the patient, and after 3 months, 6 months. So what's your opinion in such a case?
See, if I have a difficult patient, we have a very simple algorithm. If I have a difficult patient, I can always do a mini gastric bypass. Okay. Why do I need to do a gastric bypass? So only my problem is when I have a very large hiatus and severe GERD. These are the patients, where I do a gastric bypass. And if I have to do a staged procedure, yeah, we can do. See, these days you can do sleeves confidently and expect good results, and then you can convert them 1 or 2 years. So if we talk about super obese patients, like 400 kilos or so, yes, you can do a sleeve and then do a staged procedure. But if at all you are confident and you have done good amount of one anastomosis, why not do a one anastomosis directly and give the best chance to the patient? Because the weight loss in revision surgery is not as great as the normal procedure. And to me, mini gastric bypass is fantastic. Super obese patients, it's easy. And also, Dr. Imran, let me tell you, we think that sleeve is an easier procedure in super obese. It's not. The moment you go very close to the G junction in super obese patients, the leaks are very high. Yeah. In fact, if you hear Dr. Rutledge, he very correctly says stay away from that area in super obese. For unknown reasons, in super obese, there is very high incidence of superior mesenteric vein thrombosis, splenic vein thrombosis after sleeves. So my personal take is, don't be afraid to do a one anastomosis on a super obese. That the rule that you should always do a sleeve on a super obese does not apply to me, or even to surgeons who are very high volume mini bypass, because they can, like you do a lot of mini bypasses, I know. So for us, when we have crossed 1,000 mini bypasses long back, it's not a difficult thing to do a mini bypass even on a super obese, unless they have a very bad liver or some strict contraindication to mini bypass.
Sure. Sir, regarding O balloon, because also I have watched your beautiful videos, your patients are sitting and just you are doing this O balloon beautifully, and really it was amazing. So can we do this for a super obese and patient will lose 30 to 40 kg? Then we can schedule a proper bariatric surgery after 4 months.
Yes, so I'm not doing a Obalon, I'm doing a Illurion balloon. Obalon balloon is not permitted in the world now. It's not used anymore. It's the only balloon which is a swallow. Yeah, it's the ellipse balloon by Illurion. We use it very frequently in our practice for patients who are not fit for surgery. And yes, we are making them lose 30, 40 kilos and then bringing them back for bariatric surgery. It's a very effective device. It's an OPD procedure, 3 minutes, 3 to 5 minutes, and we are very we're using it in a big way. Patients waiting for liver transplants, patients waiting for joint replacement surgeries, young unmarried females, PCODs. We're using it very aggressively, and then we bring them for bariatric later on when it's preferable.
Sure, definitely. Sir, regarding, so we will talk a little about post-op, and I am interested to hear from your side about pre-op and post-op endoscopy in Roux-en-Y gastric bypass, and as well as H. pylori eradication.
So we do a urease breath test in all our patients. If they are positive, we give them an H. pylori eradication and then we pose them for the surgery. So that's very simple protocol. And urease breath test can be done. It's very cheap in India. The kit is very cheap. I don't know about Dubai or several other parts of India. It's cheap, and we do it as a routine screening. As far as the endoscopy is considered, yes, before touching the stomach, you should do an endoscopy. Never try and touch the stomach without an endoscopy. I do all my endoscopies myself on table, and then we decide about the surgery, whether, if you have a large hiatus, you do a bypass. If you have a patient with a duodenal ulcer, absolutely a sleeve, a duodenal polyp, a sleeve. So whatever the findings, and the light of those findings, we would choose the procedure for the patient. And post-op, at 6 months, all the patients are advised to undergo an endoscopy 6 months and 2 years. We don't do it at 1 year. We feel 6 months and then 2 years. So that's our protocol for all even for sleeves.
Sir, you are definitely, you are one of the busiest, I think, your center is in the world. And definitely on daily basis, you are doing upper endoscopy. How much percentage you change your decision after endoscopy? Oh, this is 5%, 10%, or 1%.
Yes, so we publish this data. It's around 5 to 8%. We have to change our decision on table. 92% times it would be the same. But around 5 to 8% we have to change, because if you have see, the problem is that sometimes not the endoscopy, but sometimes the laparoscopy can change a decision. I'll give you an example. We have had I believe more in laparoscopy than endoscopy even for hiatus, because we have had cases where patients were reported no hiatus on endoscopy, and when we put the scope inside, there was a large defect. Second thing, the liver. I don't do elastography for all my patients. We do a simple ultrasound. Elastography is too much of an overkill of resources. Sometimes they just report fatty liver, but we go inside and we find gross cirrhosis. So these are the cases, and then on endoscopy, if you have a polyp or something, you send for a frozen. It turns out to be benign, but still I feel that frozen is not something very confirmatory. We should keep access to the duodenum. So my personal take is that the decision changes 5 to 8%, and surgeon should not commit a procedure to a patient. And even if they commit, they should always take a consent to change it on table, because we might face circumstances where we might be forced to do a procedure which is not good for the patient. So better take a consent and then change it in the light of what you find inside.
Yeah, sir, regarding marginal abscess, that is also a disaster, I think, a nightmare, also for the patient and also for the doctor after Roux-en-Y gastric bypass. You have mentioned which percentage, yes, your patient, and you have exact data. What is my question? These patients, have you any data or comparative study? They were also H. pylori positive before surgery. No, you have not still any data, and maybe in future you will ask to any fellow to collect the data. So these are positive or not?
See, at my center, it's not a possibility, because we do the urease test for everybody. We don't operate upon H. pylori positive patients here. The reason is that, to be honest, there's no evidence to suggest you cannot operate. The evidence just suggests that they can have high incidence of marginal ulcers, but I don't have that kind of data, because we do not operate upon urease positive H. pylori patients. We treat them and then we operate.
No, sir, but my question, yes, sometime you treat and eradicate, but maybe in future, again, patient will be positive.
So we take biopsies. So I tell you what we do. every time we endoscope and we find a marginal ulcer, my fellow will take a biopsy and we check if it has H. pylori. As I said, we do not have marginal ulcers because of H. pylori. We do not have marginal ulcers because of smoking. We do not have marginal ulcers because of alcohol. Marginal ulcers in our center have unknown etiology. We were never able to correlate as to what was the reason for those ulcers.
Okay, so maybe in future, so we will see. So this, as already you have mentioned, this parietal mass. So maybe in these cases is little more and more acid production.
Let me tell you, it's a double hit hypothesis.
Yeah.
Yeah. For example, talking about the sweeteners which we use these days. Somebody who has a family history of colon cancer should not be on sweeteners. So the aspartame, they say, causes colonic malignancy. But again, aspartame in a patient who does not have family history is safe. So similarly, this is a double hit hypothesis, Dr. Imran. If you have a patient who is a chronic smoker and you give him a mini bypass, there are two etiologic factors: a large parietal cell mass with chances of ischemia. So then you expose him to a marginal ulcer. So always try and remember, one factor will not cause these problems. They will have. Sometimes you would not find a factor and it will be causative. You never know why. But I always think it's a double hit hypothesis. Be very sure that if you have smoking, if you have large parietal cell mass, it can cause ulcers in a large proportion as compared to non-smokers and small parietal cell mass.
Yeah. Sir, have you faced any intractable marginal ulcer? Not on your patient, definitely. You are a referral center, and what you did, especially surgical.
No, I have had my patients who had intractable ulcers, bad ulcers. Some of them perforate also. Some of them are so bad that I have to. For a perforated marginal ulcer, the treatment has to be surgical.
Yeah.
But for a non-perforated gross marginal ulcer, I admit the patient, put them on a pantoprazole infusion for 48 hours, put them on NBM, and then slowly start liquid diet, and then do surveillance endoscopies. So this is the first step, right? The first step. The second step would be, if I'm dealing with a mini gastric bypass, I would convert it into a row-wide gastric bypass, divert the bile and make the pouch short. But not at the first stage. The first stage would be to first heal the ulcer.
Conservative, yeah.
Conservative. And then the patient can be called after an interval, and then it can be converted into a gastric bypass if it does not work. Yeah.
No, sir, we are talking about Rowan gastric bypass, and I remember, so this question in MGB, so you also highlighted, because most of these cases, maybe they are suffering with malnutrition. You try to feed them with the gastrostomy tube, and then when feeding will be better, definitely this marginal ulcer will be better. And how you see the role of endoscopic surgery? So maybe you will, because debride this, I don't know. I really interested to hear from you.
No, to be honest with you, I have never used endoscopic surgery to treat a marginal ulcer. As I said, we put them in hospital, give them a pantoprazole infusion, keep them NBM. We even do not need to do a feeding gastrostomy, because simple acid suppression therapy heals 98% of these ulcers. And then at interval, we do an endoscopy, and if we find still there is some erythema and features, we convert them into a gastric bypass. We had to do feeding gastrostomy for a marginal ulcer leak. Yes, there we have to do, because we need nutrition in cases of leak. Even if you do a new anastomosis, for it to heal, you need very good nutrition.
Yeah.
But I have not personally used endoscopy to treat marginal ulcers. I have used endoscopy to prevent bile reflux in mini bypasses, but I don't have a lot of data. Manuel is now working with me. He is 10 days here at my center in India.
Yeah.
And we have a very busy bariatric endoscopy program. So we are doing a study where we are trying to create a flap valve in mini bypasses to prevent, just like a pylorus, to prevent the bile reflux. The original technique was demonstrated by Professor Zoran. I have personally, I'll have to look into my data. Manuel is collecting that data from our center. He would be the right person to, because I don't do that technique. But marginal ulcers, no, I haven't treated per se by endoscopic techniques.
Sir, regarding weight regain after Roux-en-Y gastric bypass, that is the standard technique. Definitely, this is a restrictive procedure. And as you know, obesity is a chronic disease. Unfortunately, we cannot control our patient to eat. They start to eat. So which percentage of your patients before doing that banded Roux-en-Y gastric bypass, and now because your restriction is more than that, have you any comparative study for weight regain?
Yeah, so we published the 8 years data on banded versus non-banded. In non-banded patients, we have a 30% incidence of weight regain. So 30% of their patients would gain more than 50% of their excess weight, which is lost. That's a huge number.
Yeah, definitely.
So that's why we started to band these patients. And obviously, banded bypasses will also have weight regain. It's not that they don't have weight regain, but that percentage of 30% having more than 50% excess weight loss comes down to 2 to 3%, which is good enough for us to manage.
Definitely
acceptable. Yeah. And also, all the bypasses which have regained weight, we are again resecting the pouch, putting a band, and then, as you correctly said, distalizing them to Sugarman's type 1 or type 2. But let me tell you, Dr. Imran, to revise a failed gastric bypass is very tough.
Yeah.
You're not left with many options. To revise a failed sleeve, even a failed mini gastric bypass, it's easier. You have a lot of options. Failed bypass is a very difficult ball game. I have personally started to move away from surgical methods. I'm doing endoscopy these days. So we do a outlet reduction and pouch reduction and give them 10, 12 kilos. And we very aggressively use drugs like oral semaglutide or injectable incretins, along with the endoscopic therapy for weight regains after a Roux-en-Y gastric bypass, which are not banded. So my personal choice from surgery have shifted to endoscopy, because what I realized, Dr. Imran, was that all the distalizations I did, they suffered. They suffered with a lot of deficiencies. In Indian scenario, even African patients where we did, they're not doing very good. It's a lot of need of supplements. Patients are losing weight, but they're not happy.
Yeah, agree, sir. Sir, regarding Roux-en-Y gastric bypass, what is your main concern after Roux-en-Y, after this huge experience? So this is internal hernia, marginal ulcer, weight regain. So what is your main concern?
So my main concern is not internal hernia, because I never had that. I close my defects very meticulously. No, not marginal ulcers. My main concern is that a gastric bypass without a band is a very bad procedure. It's a very bad procedure. It fails. It fails like sleeve. Believe me, people say that sleeve gastrectomy has a lot of weight recidivism. We are unnecessarily being very brutal with the sleeve. We see a lot of weight regain with sleeves because that's the most commonly performed procedure across the world. I have equal amount of weight regains with a non-banded gastric bypass. So I would say my only concern is a weight regain. And my second concern, Dr. Imran, is that it's a very tough procedure to revise.
Absolutely agree. Sir, another question regarding this band. So I remember, so when we started gastric banding, and so now we are facing a lot of complication of gastric band. So what is your complication rate of, because this is a foreign body?
Yeah. So the old band you're talking about is an adjustable gastric band that had a lot of complications, because you were trying to push it against the esophageal lumen and trying to fill in the band with a lot of fluid and trying to inflate the band every now and then. The bands which we use now are non-adjustable.
Yeah.
And they lie very loose around the pouch, if you would have seen my demonstration. So they don't cause that much complications. Yes, we have 2 to 5% of band erosions, band strictures, but most of these complications can be dealt in beautifully by endoscopy. So, if you are a good endoscopist, you have all the armamentarium available to you, the band complications of 2 to 4% would be nothing. My fellow can take out an eroded ring in the OPD and can send the patient back on the same day. So with Manuel here and with such a big team we have, But other centers, yes, if they use a band, they should be prepared for band strictures, band erosion. They should learn how to cut the eroded ring and remove it by endoscopy. They should have proper scissors to cut it, proper shears, proper armamentarium, proper endoscope. Yes, that's a very important, because even if in my series or in the series published worldwide, the banded bypass has 2 to 5% complications because of a foreign body. That 2 to 5% is 100% for that patient.
Yeah, sure.
So we should learn endoscopy and techniques to take rid of strictures, to take care of strictures and band erosions. Yes.
Sir, so much thanks. Sir, after acceptance of OAGB by ASMBS, and as you have mentioned now, at the globe, this procedure is going to more popular due to the results. So we are scientists, we are realistic, we love our patients, no doubt. How you see the future of Ruanbai? Is it will be just rescue operation after 1 decade?
I think Ruanbai gastric bypass is losing its prime time. It's already lost. But Dr. Imran, there will still be a place. Believe me, there is no beautiful treatment of GERD. If you do a gastric bypass, the GERD completely resolves. I have seen that. And why I can say that? Because I do pH manometry of these patients.
Yeah.
We have a lot of surgeons who just talk about symptomatic relief. I talk about, we established one of the finest pH manometry lab dedicated to bariatric surgery, and we have a lot of data on that. So gastric bypass will have its place because it is very standardized. It's a very simple operation to do for experienced surgeons, and it's an operation of choice for GERD. That would be the only place of gastric bypass. So the numbers would, so if we talk about the three, the sleeve will always remain the top. The second would slowly across the world, the second would be a one anastomosis, and bypass will be very limited, maybe 5 to 10% of somebody's practice who really want to offer an evidence-based procedure. They will offer. Otherwise, it will decrease in number. I agree with you.
Sir, so much thanks. Really, it was one of the best session. Also for myself, personally, I have learned a lot, and definitely for my viewers, it was one of the best sessions. Sir, your message for our youngsters.
So as I said, Dr. Imran, they need to learn all the three procedures. They need to learn a bypass and keep the algorithm very clear. I'll give you a simple thing. You have a patient with severe diabetes, very severe diabetes, lot of insulin, do a one anastomosis. Mild to moderate, do a gastric bypass, no diabetes, sleeve. You have a patient with gross liver cirrhosis, do a sleeve. You have a young unmarried female, do a sleeve. You have a patient with GERD and hiatus hernia, do a bypass. So basically, you need to learn all the three procedures, all the three. And make an algorithm for your center. You know, every country is different. Now, for example, in your country, maybe the patients eat that much amount of non-vegetarian food. If in my country, I offer a mini gastric bypass to a patient who lives, 1,000 miles away from me, not able to come for a follow-up, I might end up having a patient with a lot of deficiencies. So again, try and make an algorithm for your center. Understand the kind of practice you have, understand the kind of people who surround you, kind of infrastructure and team you have. But please learn all the three procedures. You should learn a gastric bypass, should learn a sleeve, you should learn a one anastomosis, because if you learn these three, you will not offer a procedure which the patient wants. You will offer a procedure which is best for the patient. That's my message.
Sir, so much thanks. I know you are so much busy and really always you are sportive. And also in next 6 months, we will talk about metabolic surgeries in low BMI, and 2023 we will talk about redo and definite. Again, we need your support. Sir, really appreciable. Always you are supportive and encouraging, and so much thanks, my viewers. This time you are with us, and this all interview and this educational activities is due to your support. If you have any question, you can ask in comments and professor will answer your question. And next week, also we will be with another legendary professor. So much thanks, all of you. And sir, again, so much thanks and have a nice time.
Thank you, Dr. Imran. You are doing a great job. It's not easy to take out time out of your practice and disseminate knowledge, share it with your colleagues. And it's like you are trying to transform more lives through spreading this knowledge, because the more you spread, more people learn, and the more better for the patient. Thank you very much, and congratulations.
So much thanks, sir. So much thanks. Have a nice time, sir.
Thank you. You too. Thank you. Bye.